Peter, thanks for the invitation to be involved with this session. And also, Angeli, that was a very nice call out there. And I should thank the person who...
Well, 150 scopes on one ex vivo? Was that?
We did some creative accounting on that, yes. No, but the person who actually changed my life was Ken Ford, who was at Columbia, who was the founder of SAGES with Jerry Marks, and he drilled into our heads that surgeons should be able to do this, and it took for a lot of us, as many of us out there doing it, and so I thank Ken, and then looks like we've passed it on as well. So Sharon is also part of that group. Anyway, so here are my disclosures. The simulation, the idea for simulation is a simple idea. You don't learn on real patients because it's not good for the patients. The procedures take longer and everybody's stressed out. So the idea of doing some kind of simulation where you can learn in a stress-free environment at a time that's suitable for everyone, and also be able to repeat the procedure in the simulation until you have enough skills so that you can then move on to the clinical setting makes sense. And simulation is used in almost every corner of medicine that you can think of. And I'm going to focus on the endoscopy piece of this, but certainly it's a critical part of education these days. And it's important to note that the only vetted programs for this, and educational programs with both didactic curriculums and also hands-on curriculums, has been sponsored and carried out by SAGES. SAGES has done a great job with FLS, FES, and now FUSE. And so I just want to acknowledge that. And the amount of time and years that went into those programs is notable. Now, endoscopy for general surgeons, I think, is absolutely mandatory in this day and age. You need to be able to inspect the bowel lumen to find the pathology, to also look at anastomoses and to handle complications. But also, it's important to note that in the U.S., in many communities, the general surgeon who does endoscopy is the only endoscopist for those communities. So they are the ones that are tasked with doing all endoscopic cases that come up. So it's mandatory that we train our residents to be able to do these things. Finally, there's therapeutic procedures, which a subset of the general surgeons will do, including polypectomy, EMR, ESD, ERCP, EUS, and the like. Now, the American board has recognized this, the importance of this, and has now mandated endoscopy training. And there's a curriculum, a 5-level curriculum that has to be satisfied, the didactic part, based on the FES didactic curriculum, as the residents go through their years. There's also supposed to be a dedicated endoscopy rotation that's only supposed to be more than 1 month, but at least 1 month in length. And by the PGY 4 or 5 year, the resident must get through the FES program, which has, again, the didactic and a hands-on practical. Also, as far as cases, it's suggested that 35 upper endoscopies be done and also 50 lower endoscopies be done, and that's actually now a mandate. And our program is struggling to try to get people to meet the numbers on this, which is not easy to do. Now, this is the list of skills and things, the basic knowledge points that the college American Board has mandated, and it's pretty typical diagnostic things, and also just diagnostic knowledge in terms of pathology and some simple procedures as well. Now, no matter what program you use, we're going to talk about box trainers versus computer-based trainers versus animate tissue trainers, but regardless of how you approach this, the residents need to have the time to do this, and this has been a real challenge to try to find the time in our restricted lives of the residents to get them dedicated training for this. And without the time put aside for them to train, the programs won't be successful at all, and that's been shown in a variety of studies that you need to have the dedicated time for this, and then also follow-up, real-time feedback and follow-up in order to get to have good results. Now, the first thing, the important thing for scopes, it may sound simple, but it's just the anatomy of the scope and how the scope is put together. They're not entirely intuitively constructed, I don't think, and it's important to have a basic understanding of the scopes and the differences between upper scopes and lower scopes in terms of where the instrumentation channels come out and the capabilities of each scope in terms of variegation and the like. Now, the ABS has mandated endoscopy training, but they don't stipulate what type of training simulation platform is used, and they let each program decide. Now, I think the majority of programs, if they can afford it, they're using the computer-based simulation programs and these devices. And the advantages of this is that it's a turnkey thing, and you can go in any hour of the day and you can use it. It does not require other staff. It does not require acquisition of tissue. For the basic insertion distortion skills and maneuvering skills, these are I think are pretty good. But again, the two sets of tasks, basic skills and then learning advanced procedures, are two different issues. The box trainers also, however, are cheaper. You need to have a tower and a dedicated scope for training, but this is just done with often for the colon. The colon is inside this, a plastic or rubber colon is in there, and you have to try to get the scope through it, and by changing the tethering points of the colon, you can increase the difficulty factor. And if you actually go through the programs, which involves 6 or 7 levels of difficulty, and doing a number of procedures at each level, you can in fact get quite good at this, and again, it's a reasonable platform. As far as the more advanced procedures, the computer programs do have biopsy and polypectomy programs, but they're not very realistic, I don't think. And again, the pros of the simulators we've talked about. The cons are the initial costs, and again, it's not realistic for advanced procedures. So we've turned to ex vivo porcine and bovine bowel for interventional training. And again, this is more for advanced procedures than for the basic skills. But this does require a dedicated tower that would be used just for this alone. You cannot use this clinically. You also need to have staff for this, and you have to be able to get tissue. We have a great relationship with the slaughterhouse in Brooklyn, and we have guys go out there. Cases of wine are delivered, and we get the colons. But this shows our tower, our training room, and it's basically a standard tower, and then it's the cow colon. And this is a model we designed for residents to learn how to do biopsies and how to do a polypectomy, and also how to make a sclerotherapy injection, which is something that they usually don't get or they're not really proficient at. And these are the things we needed to do it. Basically take the colon, which is cleaned out quickly, and then it's turned inside out, and then we basically take a hot nail and a candle, and we burn targets on the actual colon, and we take a hemorrhoidal bander and make actual polyps that way. Then we take a chip clip and put it on the end, and then a Bovie pad around the thing, and then you're off to the races there. So what we'll do is we'll have the residents go, 2 or 3 of them will come and do this at a time. They'll have 15, 20 minutes to do this, and they'll have 6 targets at each level. And in fact, what we found is that they were able to, within 45 minutes, to get some feel of the tissue and to be fairly accurate in terms of these 3 tasks. And again, we would then use these colons for the next thing I'm going to tell you about, which is the ESD training that we're doing. So it's a way of utilizing the tissue more thoroughly, so we get the biggest bang for the effort that goes into this. Now, for ESD, which is something that I've been trying to tackle for the last 12 years, and with limited success up until recently, it's a very hard thing to do. And I don't know if you don't know about it, basically everything we do in endoscopy is done with the scope tip stationary. If you do a biopsy, if you do a snare, the scope tip stationary, you put your instrument out, you either grasp the tissue, encircle the tissue, or inject, but the tip is not moving. For ESD, and rather than strangling the polyp, you're trying to individually cut the tissue all the way around the polyp and underneath it, and that means that the scope tip has to be moving in a controlled way with a hot needle knife extended. It may sound like it's difficult. It's very, very hard to do, and it's not a skill that we have or we learn in typical endoscopy. And because of this, adoption rates in the US and Europe have been very low in terms of ESD. The reason for that is that in Japan, where this was invented, they basically have a high rate of neoplastic lesions in the stomach that are early that they can remove with ESD. The stomach is a hell of a lot thicker than the colon, and so the trainees do 40 to 60 stomach cases before a few of them are allowed to move on to the colon. Where this is a model that will not work in the West, and so what we propose is that those 40 to 50 cases be substituted by ex vivo cases done in these models, these various models. And so we have a 3-stage thing, which I'll go through with you, and it involves an inanimate tube and a figure tracing piece to get this tip movement skills, and then bovine ESD, and then finally the porcine, and then the bovine. This is a clear plastic tube with a cutout window. We put a piece of paper with a shape over it. A sponge with a slit serves as the anus, and we put the scope through. The sclerotherapy catheter is modified with a piece of cotton in the tip with ink going through it as a pen, and then we draw the actual these figures. It's sort of like the compulsory figures in figure skating when they used to do that. I'm dating myself, but anyway, this is some of it. Looks like we've been out drinking the night before, and that's mine on the upper right there. Not proud of that. No, but the point is that you can learn. And this is my partner, Neepa Gandhi, who did not done much of this before. This is her 8 sessions, half-hour sessions, and this is the time it took for her to complete this decrease, and also the accuracy and the number of gaps and the other ways we evaluated the tracings all improved over those sessions. Each session, one of those, a half hour, then you take a piece of stomach, pig stomach, put it over the hole, and then put a bovie pad over that, and then you go to town and do an ESD here. And here, if you perforate, doesn't matter. You can continue the case until it's completed. There's no problem with desufflation or exposure, so it's a good place to start. We would do 20 of these, 25 or so, and then we would move on to the bovine colon, which is more realistic because obviously you have to insufflate to do that, and then also you can vary the location of the lesion. And so at 30 of those cases was what our plan was for this, and that's what we did. And here's my results over a decade where we were doing very poorly in terms of completion of ESD or ESD and combined EMR. But when we started the 2 training sessions, in fact, we saw that our results went up, and now I've probably done 60 of these simulated ones, and now our success rate clinically is about 80%. So this is with a practice of moderate volume. We can go in and practice this before we do it the night before if we're worried about a case. So this is a new model we think might be helpful. To summarize, the modern surgeon, I think, general surgeon needs to have endoscopic skills. I can't imagine doing laparoscopy without being an endoscopist as well. Endoscopy training is now mandated. The FES program is a great place to start, and the simulation has to be chosen, and time needs to be provided to the residents to do this. But I think then the ex vivo models are more realistic for advanced skills, and a small subset of surgeons will go on to do these advanced things. Not everybody, but those that want to do it, there is a pathway to do this, to attain these skills without having a lot of unsuccessful cases and waiting for pathology to roll along. But again, the most important thing in terms of the training piece is we have to put the time aside. If you look at any athletics, any event, sport, can you imagine being a professional football player and playing just on Sundays? I mean, of course, you have to train, and we need to do this repetitively to do so. Thank you very much.